Welcome to EuroPCR 2018. My name is Mark Abelson. I'm an interventional cardiologist from Cape Town, South Africa. And with me is a very honored guest, Professor Nick Hopkins from Buffalo, New York, who's a neurosurgeon and pretty much pioneer in the field of stroke intervention, and is my honored guest today, and we're going to be chatting about stroke intervention. So Nick, tell me, what will be the highlights of the program so far?
I think every year the data gets more and more compelling for stroke intervention, which is so similar to coronary intervention. In the last several years, we've had 7 or 8 major trials showing that stroke intervention provides overwhelming benefit for patients with acute ischemic stroke, and overwhelming benefit compared to the old traditional IV TPA. So now in 2017-18, the most recent trial, the DAWN trial, looked at results going out to 24 hours. The previous trials all looked at results out to 6 hours. So now the DAWN trial looks at out to 18 hours and again shows overwhelming benefit for stroke intervention compared to IV TPA. And I think we were mentioning the other day, how many patients do we need to treat to get this benefit? And
there was about 2.8 in the DAWN trial.
Yeah, about 2.8, and I think it was even less in the other trials. So we know that there are very few therapies in medicine that give you number needed to treat in the 2 range. So this is a pretty exciting advance, and so more and more compelling for us to work with our cardiology colleagues to figure out how to treat stroke intervention.
Yes, because obviously that is the big issue. Is we know it works, it's overwhelmingly beneficial, but the rollout is, from my side, who's been doing stroke intervention for 10 years, been very disappointed in getting more people involved. Even the neurointerventionists are often reticent to be called out at night.
Right. You and I were at meetings here 3-4 years ago where we were almost the only people in the room.
Yeah, it's always disappointing that.
Yeah, there might have been 5 or 10 people.
And now how was the attendance at this meeting?
Yeah, the last 2 days has been extraordinary, because now larger rooms are filled to capacity and people are really showing much more of an interest. And so that's a very exciting thing, because if you look at the world of stroke, every year in the world there are somewhere near 16 million strokes, and 85% of those are ischemic strokes, as we know. An ischemic stroke that has a large blood vessel like a middle cerebral artery or a basilar artery that's occluded. Those patients are the perfect candidates for stroke intervention. So patients with large vessel occlusions comprise about 30 to 35% of all acute ischemic strokes. So you look at those numbers, there are a huge number of patients in the world that need treatment. The other really exciting thing from my standpoint is the realization, looking at the subset analyses from the previous trials in the last few years, what we've found is that if you look at the population as a whole, that about 2 hours is the key time limit from onset to revascularization. If it takes 6 hours to revascularize the patient, then overall the results are down in the 20 to 30% range. If you can get it open within 2 hours, in general, the results can be in the 90% range for complete or near complete recovery from an acute ischemic stroke. That is a revolution. Yeah. We've never heard of anything like this in medicine before that I'm aware of. Yeah. So very exciting stuff.
It seems so obvious. The artery's blocked, open the artery, which has been my feeling as a simple cardiology plumber.
Exactly.
For 10 years, but
me too.
People were always saying, no, there's much more to it than that. But
that's right.
So Nick, what about the training? Because that's the issue, is getting cardiologists involved. What training do they need? And there's a lot of legislation issues, I think, but there is a pushback by the neurointerventionists to not have cardiologists involved. But in the short term, millions of people are suffering. And what do you think about the training programs?
Very interesting topic, because if you look at the neurointerventional community guidelines, they look like a simple turf barrier, but in reality, the way they were designed originally was for first-time users, because the person who goes through a neuroradiology residency, he hasn't done much of any catheter intervention when he gets to his INR fellowship. So the fellowship guidelines are really designed for starting from scratch. And what I think they ignore is the fact that interventional cardiologists are very skilled at catheter interventions. As a matter of fact, if you think about what do cardiologists do all day, they open up occluded arteries, exactly what we need for stroke. But they do it on an awake patient in a moving target because everything's moving in the heart.
With bifurcations and lots of calcium.
Absolutely,
and,
absolutely.
You've got 3 wires down. Technically, I don't find it a challenging procedure.
Well,
when I tell my neurointerventionists that, they have a dig at me, but...
Yeah, that's my question for you. How difficult is it? Compared to the average coronary intervention, how difficult is stroke intervention?
Yes, it is difficult
for a cardiologist.
for if you've got a type 3 arch, bovine anatomy, there's no doubt getting access up to the internal carotid is the challenge.
Yes.
But once you, and many patients don't have those types of anatomy, so let's start off with that. Many patients are type 1, type 2, right Judkins, easy to get up there.
Right.
But that's the challenge. Once you're up there, you know, crossing the obstruction, microcatheter, deploy the stent retriever, and Bob's your uncle. It's really a walk in the park from there. That's
been my theory as well, is that once cardiologists learn the basics, now it's absolutely necessary to learn the basic anatomy. So I think focus on the carotid anatomy, the skull base, and the intracranial circulation. But I don't think cardiologists need to learn about all the distal circulation. I think if cardiologists learn the major branch points and the major vessels, because we know that those are the arteries that, when they're occluded, are the ones that can give the maximum benefit when you reopen them. Yeah. And all the rest of it, if you look at all the anomalies and all that kind of business that the neurointerventionalists deal with every day, we don't have to worry about that as interventional cardiologists. We have to worry about the main artery that's occluded. How do we get it open? And then my supposition is that down the road, you're going to see patients who have a really complex problem. If we can get them to a STEMI center right away, get the artery open, then if it's a complex neurological issue, then they can be transferred to a neuro center with an open artery and a brain that's being reperfused.
No, absolutely. So then, to end, Nick, where do you think this field is going? Just to summarize and...
yeah, it's a great question. I think, if you look at the fact that there are 16 million strokes in the world, and if you look at the number of neurointerventionalists that are available to treat them, it doesn't even treat a small fraction of all the strokes. So we've got to have help from our cardiology colleagues to handle the public health issue of how do we treat these patients. If we can return a patient from aphasic and hemiplegic and completely out of it, nursing home candidate, if we can return that patient to an essentially normal life, it's a huge benefit to the public health. So we have to figure out how to satisfy the public health, ignoring turf, and working on ways to get cardiologists enough training to understand the basic needs for opening up a cerebral artery.
Yeah. Well, yeah, it is my hope that in the next few years we do see this growth in cardiologists doing stroke intervention and offering services which are currently not available because the neurointerventions are just not physically there.
Exactly. That's my hope too.
Okay. Thank you very much.
Thanks, Mark.